You're listening to Ride Along, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the Ride Along.
And we're back.
We're here.
Wait, are we though?
Are we really anywhere?
We're not all here, because some of us have to work.
Yeah.
And for a change, it's not me. Haha.
Yeah, we'll just throw it out for once, right at the start of the episode. Jonathan's not here, so anybody who's looking for like the wised, learned EMS provider, he won't be here for this episode.
Nope.
Yeah.
Not even for his section.
I can't even call him a slacker because he's off working and doing EMS stuff.
Well, sure you can.
Okay, he's a slacker. He could do both.
He could.
That would be really tough.
He could phone it in.
Can you imagine? Like, well, we did do that episode once where he like you heard his radio traffic in the background. Or could you imagine having to deal with like tones dropping in the middle of a point that you're trying to make?
Hold on, guys. Ma'am, it's going to be okay. You're going to be okay. Talk to us, Jonathan. Tell us what's happening.
Yeah, just walk us through it.
Come on, live from the field.
Yeah. Well, we don't have Jonathan tonight, but we are continuing in a conversation that he was here for in the last episode.
Yes.
So in the last episode, we were talking about what head and skull and facial trauma. Right, the headbanger's ball.
Exactly.
Right. Well, this one is another little classic metal like homage.
Yes.
So this episode is Spinal Snap.
He's very proud of that title, as he should be.
I think it's the best title we've had so far.
It might be the best title.
And it definitely gave me the excuse to watch the original Spinal Tap trailer today, which then, like, my wife walked in while I was watching that. She's like, "Are you watching Spinal Tap?" I'm like, "Yes." She goes, "Did you know there's another one coming out?" And I'm like, "What?"
Oh, you didn't know that?
No, I had no idea.
Oh, I thought you knew.
Yeah, so I was like, then I immediately had to watch the Spinal Tap 2. I think the like the subtitle is like the end continues or something like that.
Yeah.
And it looks as hilarious.
Yes.
Like the whole crew's back. Rob Reiner's like the documentarian again.
Yes.
And then the funny part is, like, it's become so established as part of like the metal zeitgeist, if you will. Did you see who's in it with like
no, I didn't.
all the cameos and stuff?
I mean, I'm not surprised.
Just from the trailer, like Paul McCartney's in it.
Of course.
Elton John's in it. Questlove.
Damn.
Like he makes a cameo in it. Like they're going to pull out all the stops in the trailer, right? But I'm excited for it because I think that's hilarious.
My question is, what will the amplifiers go to this time?
Oh, they're going to go to 12.
They have to.
Yeah. Oh my God. It's the best, one of the most classic scenes in movie history.
Well, see, our amps go to 11.
Yeah.
Because it's one.
But why don't you just make it like, why don't you just make 10 louder? Like make the 10 louder and then just like the perfect comedic pause. Well, but this one goes to 11. It's like, it's the best writing ever.
Yes. And by the way, it has affected like so many things that have like what should be there's so many things that have a 1 to 10 scale, yet go to 11.
Yeah. Go to 11, guys. Like,
exactly.
That's how we've approached EMT school.
Oh yeah, absolutely.
We've gone to 11 in
right
every
away.
instance we possibly can.
Yep.
But yeah, so tonight we're talking about spine.
Yes.
The spinal snap, right? Like, all the things that could be happening to the neck, the spine, all the way from the top of it, like the C1, all the way down to the tailbone, the coccyx.
Yes.
I think
yes.
Yeah. So
the coccyx is like the dead end.
Yeah. All the way down to those fused 3 little prehensile tail bones that we have that serve no purpose other than to get hurt while you're snowboarding.
Or falling downstairs.
Or, that too. I bruised my tailbone years ago doing it from snowboarding. My wife has done it too, where it's like it just causes excruciating pain.
Well, my wife, when my daughter was very young, did it twice. She went downstairs, and all she could do is just grab the baby and ride the lightning. And then right before we moved, she managed to do it again by tripping over a dog.
Oh, man. That was recently, right?
Yes.
Yeah.
And then she was completely useless for the move. I'm sure it wasn't a premeditated thing. I love you, honey. But yeah.
Yeah. Backs are the worst. They seem so fragile, and they have so much impact on everything else that we're doing.
Yeah.
Like it's literally the thing that holds us all together is that one common string of things. And then it, aside from it also being a structural element that's flexible, that supports the whole thing and allows us to move, it also is like our primary data corridor, which has all of the information running through it all the time.
Seems like a bad design.
Only all of it.
I'm just saying, like, the head has all these things going on that, if you pierce it, you might have a problem. You might still be okay. But no, this thing is going to have all the critical things you need. And if it just gets bumped out of alignment a little bit, you're screwed.
Oh yeah. Bumping a vertebra out of alignment. I have a herniated disc that comes back around every now and then, which is the worst.
Yeah.
Like it can literally lay me out to the point where I'm non-ambulatory. Like I cannot bear weight on my lower half of my body.
Yeah.
I dread those times because it could just happen. All because of some weird little thing.
It's always something stupid. Always something stupid.
So yeah, that's what we're talking about tonight. Yeah. But let me ask you: Have you been riding at all, Max?
Yeah. So I did a 12-hour shift about a week ago. It was fun. It was weird. Like I didn't expect. Like I've been pretty calm on every call. But like I was like, why am I so nervous? Like why all of a sudden? It's just because I have a certification now. But like it was weird. It threw me a little bit because I didn't expect it.
Yeah.
It's like it's just felt different. Like
Well, I think
there's a weight there now that I didn't necessarily have before.
Yeah, I think it's also important too, because and this isn't to call you out. It's just to say like the way we've both approached how often we've been volunteering has a huge impact on how recent it feels each time you do it. Because you had so much stuff going on in your life, you couldn't do it for probably a few weeks at a time, or you'd get one in. And I was doing that too for a while. Whereas like whatever I can get, and it might be once every 2-3 weeks. There was one point, I think, in the last month or so where I went on like a 3-week hiatus where I was like on vacation, and then I didn't have any opportunities for a shift the next week. So it was like 3 weeks before I was like on a shift, and I got back on. I was like, oh man, I do not remember. I couldn't even remember going to school. Like it was just like
that blinking thing with the lines.
It is so important to do a regular schedule. Yeah. I would recommend for anybody out there, listening, just from my recent experience of like what I felt's been good for me is hooking up with a service that allows you to have at least a regular kind of slot once per week is optimal.
Yep.
I've been lucky in that for my hometown agency, I've been able to kind of like get into a groove where I'm like Friday mornings, like are the mornings that I'll be there. So that's been great. Like all this month, I've been there on Friday mornings.
Because as you know, like you could go 2 shifts and not have a single call.
Yeah.
It's possible. So if you're not doing that regular thing, even if you wind up in a situation, like you may not get a call that week.
Yeah. And I'll say this too, because I've been working on a extracurricular project for my agency. They did not, when I started, they did not have a checklist, something that I could reference as a volunteer or a new EMT to say like, where is everything on this ambulance? Like you kind of have to just learn where it is. I didn't have something to reference to go, where would it be? What's the organizational pattern? Like what's the plan for in here? And then especially like, what are the critical items that need to be checked? Because you can't check the entire inventory of an entire truck every morning. Like it's just not practical to count every single thing in every single bin. Right. So like there's usually a critical checklist.
Yes.
Like you have to make sure this is good, that the Lucas battery is charged,
Anything
that
battery powered.
the life pack is charged. So like there are the mandatories, and then everything else is kind of like usually a glance, but they don't tell you. They didn't tell me that. And I've found at other agencies that they don't necessarily tell you that either. So I've taken on a personal project, like an extracurricular thing at work or at my hometown agency, to do that list for them.
Right.
And so when I'm not on a call, I'm not just watching the TV, you know, effing off, doing whatever. Cause that's what a lot of people do is like, oh, what's on Netflix? I'm trying to keep my head in the game. Cause if I'm not on a call, I'm at least figuring out where the things are and how to be better with the like where the things, how to be supportive of my team, where the IV flushes are. Right. You know, and those are things that we aren't necessarily taught in school that like can be super helpful. I've also, so this is my big progression. So this week, within the last week, I started leading calls.
Nice.
Which is, it feels like I'm back at square one.
Yes.
It's just like totally different from like hey, I'm going to be the third seat and just watch and you tell me what to do all the time. It's like, okay, with a real patient, I have to assess, figure out all the things. Thank God that there's like very skilled and awesome paramedics and AEMTs and all these other people there that are willing to give me a chance to go, hey, don't forget this thing. You know, do that. Okay, yes, because sometimes like you just need like you're going to learn it by doing it, right? So
yeah, 100%.
That's been wild.
I had my first time doing anything like that, and I beat myself up about it for no reason, ultimately, because I realized, and after I talked to you about it, and after I came back around to it, like, I did do all the things that I should do. Did I vocalize it properly? No. But I did assess it and clock it and be like, okay, that's a thing.
Yeah.
But unfortunately, I didn't vocalize it.
Well, what are you talking about specifically?
So specifically, what was doing a stroke assessment.
Okay.
And like when I moved into the patient, like I immediately looked at him and I clocked, okay, facial droop. Did I ask him to smile? No. But like he had a very obvious left side droop. So I clocked it when I glanced at him and then moved on down the line.
Yeah.
I didn't verbalize it.
Yep.
And you do it. There is a value to verbalizing it because it allows you to categorize it in your head that you've gone through this checklist.
Yeah, because what I've found about this job is it's not just about what you know you've done. It's about what other people know you've done too, and them challenging you to be like, hey, did you do a facial assessment? And if you don't say, oh yes, I absolutely did that, you may have that moment where you're like, oh, I don't know if I did that. I may have passively done it.
Yeah.
But we don't have a passive job.
Yeah.
We have an active job where there's a reason we go through the primary assessment, the secondary assessment, the scene side, we do these things in order and we do it because like we have a procedural
and
job.
You need to chart what you're doing too.
Yeah.
And not being able to chart it that, yes, I asked this question leaves it up to a subjective end that no one's going to be happy with.
Right.
So anyway, it was a valuable point. And then when I was kind of confronted with like, hey, what's this thing? Like, what is this? I immediately, I stopped talking.
Yeah.
Like I don't remember how to talk. But I'll tell you what, on the ride back, like I looked so far deep into it of like, okay, this is never happening to me ever again. Which again is a valuable moment of like, okay, like I am not going to have this thing that I am not forgetting or not being able to at least explain why I'm doing what I'm doing, because you have to be able to do that.
Yeah. I did the same thing. I haven't even got to told you about this, but not that particular, not like a Cincinnati stroke scale assessment. One of the first calls I led is like, okay, I'm going to practice being a lead provider on this, and I'll call like, I'll set the tone and do the interview and all this other stuff. I go through the whole thing, and like there are some things that I'll look at and go, okay, I did very good at this. Like I was very good at like it was a fall victim. it really was a lift assist, but it was, okay, we need to go through the full Monty of like, okay, did she hit her head? Is she on blood thinners? Are there any other injuries? Because she fell on her hip. She had hip pain. Like, we need to do a physical assessment, figure out, is there any rotation of the leg? Are they different lengths? So checking for hip injuries and all these other things and other physical deformities and all that. I did that stuff okay. And I don't usually, like I try to not be super critical on myself, but there are the biggest deficiency I had was in slowing down, and which usually isn't, I mean, that's a problem for most people because they get wrapped up in the process. And I got through that whole thing. I talked to her. I interviewed her. I asked her all the right questions. I asked her if she had allergies. I asked her if she had any medications she was on. What was her past pertinent history? What time did everything happen? What were the events? Like all the OPQRST sample stuff. I was like, okay, I asked all the good questions. And then it came time to move her or for her to sign a refusal because she didn't want to go to the hospital, which is fine. We gave her all of the information. And then afterwards, I was like, I could not tell you any of the vitals. I could not tell you any of the information, the specifics about what she said. I couldn't tell you. Like, I asked the question of what allergies do you have? And she answered with one of them, but I couldn't tell you what it was. Yeah. So thank God I had partners there that were scribing as backup for me because A, I'm new, and B, you do that for your partners whenever you're out there. Like if somebody's asking the questions, usually somebody else is going to be writing the stuff down unless you have the sheet and you're writing the stuff down. But I learned a very valuable lesson in the sense that like I should not be just charging forward in this stuff. I need to make sure that I'm capturing all of that as well. So I got done with that call. I'm like, oh, I have a notebook on me. Why am I not using it? Like there's a sheet that they give us that has all the information on it.
Mr. Notebook.
Yeah, I like notebooks, but like, it's just to say that like we all like when you start doing this stuff, it's not school anymore. No. Like it's not like, oh, this is a formulaic thing. It's like, okay, we're just going to go through epistaxis and we're going to do epistaxis 6 times in a row, or you're going to do a log roll, challenge station. Yeah. It's not that. It's more dynamic. It's more fluid, and you have to find your rhythm, and you have to find the way that it works for you to make sure that you're still doing all the procedural stuff. Yep. Anyway, that was the kind of my learning over the last week or so is like I need to find my rhythm, and I need to figure out how I can capture all this stuff, but still have a natural like patient interview. Yeah, which is hard. It's hard to scribe and to do that at the same time.
And then some lady's gonna like, what are you talking about? Or you're gonna have the son that's gonna interject with his concern. Yeah, and then it like just throws your OODA loop, and then being able to get back on track.
There's already been so many instances where I'm like, it's like the patient's daughter, and she's like throwing out. Like, oh, well, 2 weeks ago, she had a urinary tract infection. And then like 3 days ago, she had a hangnail. And then, 2 months ago, there was she got her hair dyed and it was in there a little bit too long. So it came out too dark. She had a little bit of irritation in her skin. I'm like, ma'am,
what does that have to do with the fact that she broke her finger?
Yeah. Like, why are we here today? Oh, well, she has a stomachache. Cool. All right. Like it's just like it, and for those of us out there that have trouble with like stimulation, like all of this stuff, like nailing you at the same time, you have to find that way to like, all right, let's cool all this down. Let's figure out how we can focus on this one most important thing.
Customer service, baby.
So hard.
Customer service, baby.
So hard. But yeah, so. A lot of learning, you got to get out there and do it. Please go out there, volunteer, get on a regular schedule. And there's no substitute. I wish it was more complicated. I wish there was a better secret than that where you could just download the stuff into your brain. Like going out there and doing has really been the thing that solidified all the knowledge.
Absolutely. I cannot agree more.
But yeah, so that also leads us into the topic of today, because even today I saw I was volunteering this morning. Both patients this morning were fall victims. Yep. Today was like fall, spring. I don't like. It's the first week of spring.
People are up and moving. It's nice
everybody's.
Weather, so you're going to see it.
Everybody was. There was even after I was done, there were 3 more fall victim calls that came in today at that agency. I'm like, geez, this is it's weird. You'll find that like sometimes you have weird days where there is a theme to the day. Like it's trauma day.
Yeah.
Or it's psych day. Like it just happens. I can't explain it.
Well, it could be throw up day. So it could be as bad as your day is, it could be vomit and poop day. It could always be worse.
Yep. I had breathing day.
I had one of those too.
Yeah, I had a day where all 2 of the patients I was on in a 6-hour shift, I had to bag. Like I was like, wow, that's weird because you never do that. Like, no. And both calls on the same day, I was ventilating and breathing for somebody. I was like, this is weird.
But again, get out, do it.
Yeah, and then you get to go, wow, that was weird.
Yeah,
that's the best part about this. But anyway, today. Couple of patients, both of which needed a assessment for spinal motion restriction. So that's the tie-in for today is that, and long story short, we did not use spinal motion restriction on them.
No?
We're going to talk about that some tonight in terms of trends and things changing and stuff they went over with us in school, things we hear from people in the field.
Yes. You'll find those 2 things can be very different.
Yes, exactly. And especially that in conjunction with what used to be done.
Yes.
So we'll talk about that some.
Yep.
However,
bring us into the medical term of the week.
Yeah, let's start with the medical term of the week. We like to start here because it gives us like a concept that we can hold on to throughout this. Now, I won't say this is something so integral into every time that we're going to see some sort of spinal injury.
But if
it's involved, it's something that's like you should look out for and help you understand why things are going poor so quickly.
Yeah.
And it's a concept that we're like, or a key term that we should have heard several times by now.
We've mentioned it before.
Yeah, but we've never taken a deep dive into neurogenic shock.
Correct.
And I needed a refresher on it too, because I never truly understood it. Like some of these topics in the medical term of the week, I don't necessarily truly understand until I go into this type of thing where let me kind of figure this thing out. And neurogenic shock was something like I heard about it. I understand it has something to do with the neuro system. Mm-hmm. You know, it's in the name.
It is.
And I'm like, and in my head, it kind of just lived there for a while.
Yeah.
So now we can tie it all together because we're talking about injuries to the spine.
Yeah.
And the spinal column and how that ties in. So it's still shock.
It is.
It's the body lacking perfusion. Mm-hmm. Like the blood stops flowing with oxygen to deliver like the needed nutrients around the body. Mm-hmm. Right. That's what shock is lack of perfusion.
Yeah.
But why? That's the big one. So in this case, it's a type of shock caused by a loss of sympathetic nervous system tone. So I read that definition. I'm like, cool. So what the hell is that? That doesn't really tell me it. Like, okay, I get it. The sympathetic nervous system. I understand what that is. Mm-hmm. That's what happens in the body in response to injury, pain, stressful stimulus, right? Like, you know, that's what our body does when it thinks it's dying.
Yes. It
usually increases the heart rate.
Yep.
Right. It increases the blood pressure because we get vasoconstriction.
Yep.
Right. We have pale, clammy skin because our kind of, you know, our vessels close up. Yep. These are the typical signs. Oh, our breathing rate usually increases. So it's the fight or flight. So, hey, we're getting ready to run from death. You know, that's essentially what's happening. So that's the typical response to shock. Those are the typical shock symptoms. But there's a shift with that with this particular type of shock, right? So sympathetic nervous, neurogenic shock usually happens in spinal cord injuries where it's above the T6, the thoracic 6 vertebra. So relatively high in the body. We'll talk about that in a second, like the anatomy that we're talking about. But what happens is if there's a significant injury to the spinal cord there, you get widespread vasodilation.
Ooh, that's not good.
No, it's not good because typically when your body is in that fight or flight mode, you get vasoconstriction, and it raises, like, basically that helps stuff keep moving, right? It keeps the blood pressure up.
Because you're running from a saber-toothed tiger.
Exactly. Or like you have, like in hypovolemic shock, if blood's pouring out, it vasoconstricts and then slows the bleeding in that area so that you're not leaking out everywhere, right? So widespread vasodilation is really bad because all of a sudden everything gets real loose, and it's like basically a real tiny rapid river turning into the Mississippi real quick, real low, slow, wide, and not moving very quickly. Yeah. So you get lack of perfusion. So here are the key things that happen with neurogenic shock. You get hypotension
from that relaxation.
Right. You don't get the hypertension, you get hypotension.
Right.
So you get lower blood pressure, which is obviously a late sign of all shock.
Right.
Like that's decompensation.
Exactly.
But with neurogenic shock, you start getting that lower blood pressure right away. You get bradycardia.
Right.
So instead of tachycardia, you get lower heart rate.
Right.
You get warm, dry skin, which is the opposite.
Is odd, yeah.
Because with that vasodilation, the blood is kind of flooding through the system instead of it's not being pushed through the system, but you're not getting that kind of extraction of blood from like the extremities where you're getting that cool, clammy skin. And you might have possible paralysis or neurologic defects, like the things that you would expect from a spinal cord injury, right? Okay, so there's a few things in there that are different than what we usually expect with shock.
Yeah.
Right?
Yeah, for sure.
But why? So that was the thing. I was like, okay, cool. Like I can look for signs and I can understand differences, but like, why is it different?
Right.
And the reason is because we have nerves that trigger sympathetic responses.
Right.
I think we talked about it last week with the Cushing's triad, where if the jugular veins the carotid arteries get too much pressure in them, it triggers the baroreceptors, like the nerves that then cause other things to happen, right? So the same thing happens here, where if those nerves get triggered, it causes a bunch of different things. So when you have an injury to the nervous system, it disrupts those sympathetic responses, right? So that means that your blood vessels are no longer constricting; they dilate, and it causes those downstream effects. So the blood vessels dilate and causing the blood to pool. The heart no longer has that sympathetic stimulation, like it's not getting the impetus to start beating faster to push more blood.
Right.
So it slows down, and the result is that decreased perfusion. So it's that parasympathetic response from the nerves kind of getting blocked off.
Right.
That means that the whole system's just not getting the warning sign to, hey, kick things up a notch, right? Here's the interesting thing about it too. It actually, like when you have neurogenic shock, it doesn't respond to some of the things that it would normally respond to. So like epinephrine, for instance, cardiac epi, it's a pressor. It presses the system, right? It constricts everything. It will work, but only a little bit, because epinephrine doesn't work all like 100% through the nervous system. It works through the bloodstream. So it can affect things directly that it's reaching through the bloodstream, but it also affects the brain, which then signals down to like kick in the sympathetic response. But if that's not happening, it doesn't push the system. It doesn't press the system like it normally does. So epinephrine has like, a reduced response for those types of things. But like they may be non-existent altogether. You may not get any response from those things that are usually creating a sympathetic response.
Yeah, if the highway's cut off, like that's it.
So really the story is those nerves play a critical role. If they're not transmitting the data that says, hey, we need a sympathetic response. Hey, you're dying. Make the heart beat faster and close all the blood vessels. If it's not sending that information, that's neurogenic shock. Yeah. Right? So what does it really mean? It's very much bad.
It's bad.
Like there's nothing you could really do about it in the field other than try to get them somewhere quickly.
Try not to make it worse.
I don't know what the definitive care is at a hospital for neurogenic shock. There may not be some. But one thing's for sure is if you can keep those primary things like the airway, the breathing, the circulation going, maybe they can do something about it when we get there.
My assumption is they'll just they have machines that will help your heart run and help your lungs run, and they'll just artificially get those things moving.
Maybe. I think what it would probably be is the best case scenario is if there's some sort of temporary pressure or problem with the nerve, that if you can keep them going long enough and then somehow they can help alleviate either the disruption or the pressure on the nerves, then that would then kick the system. Because I don't think the body can survive in an environment where it's not getting that sympathetic response. But so that's one of the reasons why traumatic injuries, motor vehicle crashes, like those things are so bad, because it's not just hypovolemic shock that can lead to death. It's the neurogenic shock too, where, hey, they may not be bleeding anywhere, but if they have damage to a nervous system, that will tell the body to just shut down. It won't it's not even telling it to shut down. It's saying, it's not even sending the response
everything's
to
fine. Relax.
Everything's fine.
Today's your day off. You just need to sit back.
It's the dog.
Right.
It's the dog in that meme sitting at the table with all the fire around him. He's like, everything's fine.
Everything's fine.
Yeah. But yeah, so we got to do all that stuff. We have to maintain spinal motion restriction. We're going to be talking about that a bunch.
Indeed.
Yep. Support the airway and breathing, provide the oxygen to help with the perfusion, right?
Yep.
Assisting ALS with whatever they're doing. If they need to push meds, helping them with meds, and then getting them somewhere where they need to be super fast.
Yeah.
As fast as you can, with due regard, of course. And, monitoring that hypotension and the bradycardia, which are the kind of big things to watch out for, where if it's neurogenic shock, because if they're having poor perfusion and they have low heart rate and low blood pressure,
then it's a pretty clear indicator.
It's definitely trending more towards, especially if you notice that the mechanism of injury is significant and traumatic.
Yes.
And you're like, hey, I think this is this.
Yes.
So that's the medical term of the week.
I would say
neurogenic shock.
That's it. We're done.
Yeah.
That's the end of the episode. We've told you everything you need to know.
How much deeper do we need to go on this stuff?
Exactly. Like 10 minutes. You're happy. We're happy. Jonathan's not here. He doesn't feel bad for missing a nice long one. So
yeah,
but no. So we should probably explain maybe a little bit about the spine itself when we talk about the anatomy of it.
Yeah. Why don't you bring us through, Max? Because you're very familiar with the spine.
I am, through painful lessons learned over years. So the spinal column protects the spinal cord and supports the head and body. And there's different sections to that spine. So you have the cervical section, which is the part between the head and the thorax. And you have the thorax section, which again goes from there through the chest cavity area.
Yep.
Then you have the lumbar section, which is the one I'm the most familiar with.
Yeah, me too, unfortunately.
Yeah, and then you have the sacrum and the coccyx. Coccyx being that tailbone.
Yeah.
So you have your cervical vertebrae. Two important ones are the C1, C2. That is the atlas and the axis. That's kind of where everything moves and pivots on for the head itself.
Right. Yeah.
And then you have the thoracic vertebrae, which is T1 through T12. That's the largest section of your spine.
12 of them?
There's 12 of them.
Jeez.
12 opportunities to ruin your life. And you had mentioned for a neurogenic shock from T6 above.
Yeah.
Like that's really where you see when there's an injury in that section, because it's between your heart, your lungs, and your brain.
Yeah. And that's the way I think about it too. And I don't know if it helps for anybody else out there. When I hear cervical, like sometimes I get thrown off because cervix, like on a female anatomy, is something is in the pelvis. Yeah. And you're like, wait, but so like, instead of necessarily thinking cervical, I think neck. Yeah. Right. And then for thoracic, I think that's chest.
That's pretty straightforward.
Yeah, like
and lumbar, the lumbar section.
Yeah, lumbar. I think back, and then like the sacrum and the coccyx. I think butt.
Useless.
Yeah. Well, the hip back, basically. Exactly. And like that thorax is like that's where all the
It's
super
where
important,
all the important things are.
the heart and lungs.
They're a little bit important.
Yeah.
But the reality is, like, you have that structure that's there. And yes, you have musculature alongside of it, but you have those nerve bundles that are running. And my issue is that I lift heavy things for a living and have for a very long time.
You pick things up and put them down.
I do. And you're in between each vertebrae is a disc. And that disc is kind of a spongy material.
It's cartilage, right? Like,
it is type of cartilage.
Yeah.
And it kind of absorbs some of the shock. Well, funny thing, when you compact that long enough times, it just starts to wear away. And in my case, the vertebrae between my sacrum and my lumbar region, that very first disc is basically not there.
Yeah. Is that arthritis or a form of arthritis?
It's degenerative disc disease.
Degenerative disc disease.
Lifting heavy things for a very long time.
But it's interesting to kind of bring that up, though, because like I also have like a lower back issue. Like I have a slip disc or a herniated disc, whatever they call it. But like even those types of things, which are chronic issues, can turn into like,
oh, sure,
emergent issues.
Yeah.
Because like I've had it so bad, and I'm sure you have, where it's like I become non-ambulatory.
Yeah.
Like that one thing is so integral to your ability to move around. And if you can't move and you don't have somebody there with you to feed you and to like give you water and like make sure you're not dying on the ground, you need, like, that is an emergency situation. Like, you should call 911, which is what we wind up dealing with a bunch in emergency services.
The worst I've ever had it, I could not stand long enough to piss. Like, I could, but like I had to I had to hang by like the shower curtain and like the sink and then try and point. Like it was a mess. Yeah. It was an absolute mess. And then the wife was like, "You're being stupid. Stay in bed. We'll deal with it."
Yeah.
And of course I didn't listen to her, because why would you want to listen to your wife? It's just silly. But yeah, so in each vertebrae includes a spinous process, or the bony projection that felt along the back. So there's that little bump that if you run your hand in, you can kind of feel it. And we'll talk a little further along about, how you palpate that and see if there's an injury there. And that's one of those things that's a clear indicator if it's out of alignment that you may have an issue.
Yeah. All right. Quiz time for you, Max. What's the hole called at the base of the skull where it meets the atlas? Right? Is that that's C1? C1 is atlas. Yeah. What's the hole called?
We just talked about this last week. I know it's there. I'm trying to not look at it.
Okay.
I saw it and I was like,
I'm like, it's in the notes.
I looked at it and I heard you starting. I was like, it's going to be about this. For something.
Foramen.
Foramen. Foramen. A Slavic name. A Nordic name, right?
Yeah, it could be.
Kind of, right?
Magnum.
Foramen magnum.
Foramen magnum.
Yeah.
That's the hole at the base of the skull.
If things are trying to force their way out of there, it's bad.
Yes, we've learned that last week with the intracranial pressure.
Yes,
which could also cause issues with the nervous system.
It can indeed.
Yeah,
and then we have the worst. There's many parts of the body that I think are a mistake. Like, as clearly they didn't think through this hard enough. And there's one part of the body. It is literally, I think, the most vulnerable part of the human body is the neck. It's a horrible design.
Well, there's a lot of squishy parts of the human body, but the neck is definitely one of the hardest part about the neck. And like, if you really look at like the way like anatomy has evolved, like since animals like walked on four, like if you believe in that type of thing, like science.
How would you want to think that?
It's weird. Especially working in a medical field where we have to deal with anatomy and can see all the different things.
If they're going to refer to in Latin, it's got to be real. That's all I'm saying.
But like, the neck is such an important role for like a body to be able to move and see.
Yeah.
Right. Like, it's the way we process the world. So it has to be able to move. But on top of it is this big, heavy morning star of a body part.
Yes.
That, if you move things too quickly, becomes a really terrible mechanical arm, or arm meaning like the force term, right? So if your body moves and the head doesn't want to move, it just whips the neck around and you get whiplash.
Or if the head continues to move and the body doesn't.
Yeah, same thing. Yeah. Like it's terrible. Like, it's just not as supported because you got this tiny spindly little spinal column, and then you have some ligaments and
connective tissues,
some muscles and stuff holding it all together. But like, it's not like it's the rib cage where it's like an armored structure around squishy parts, or the skull where it's literally like an armored dome. It's very susceptible to motion and overextension, which causes a bunch of problems.
You know what it reminds me of? It reminds me of the Batman movie where he says, "I'd like to be able to turn my head."
Yeah.
But that'll increase weakness and make you vulnerable. Yes, but I'll be able to turn my head.
And it's important. It may make us squishy, but it's definitely important to have a neck, right?
It is indeed.
Which is the cervical area. And we're going to talk about later, probably talk a bunch about cervical collar, collars, where those come into play with the neck. But here's the reason why the neck is so important. There's a bunch of life critical structures that go through the neck. Here's just a few of them. Well, the big ones.
Yes.
The carotid arteries.
Not important.
Oxygenated blood coming from...
You only need one. Yeah. You only need one.
Oxygenated blood coming from the heart going to the central processing unit of the body, the brain, right? And supplying all of the information and all of the control for the rest of the body. That's obviously super important, right?
Yes.
You need that going to the brain. But when it's done in the brain, you need all that blood coming back so that it can recirculate again.
Yes.
So you have the jugular veins. So 4 opportunities for really big, important pipes to be compromised, right? 2 up, 2 down. You have your trachea.
I mean, it's not like you're using it for anything. Oh, wait, you're bringing oxygen to the lungs. That way you can have blood flow.
Yeah, it's probably the single most important thing in all of anatomy and EMS is like the A in ABCs is making sure that the airway is open, because most of the time, if we're seeing a problem that is so emergent that we need to act right now, it's airway related.
It is indeed.
Right? So, the airway, the trachea, that is going through the neck. You have the esophagus, probably less important than the other ones.
But if you don't...
It's still really important.
If you can't use it,
you die.
You die because you can't get all the things your body needs to be able to run.
Yeah, you can't get water and you can't get food into your body, right? So the esophagus, super important. Oh, and that thing that we've been chatting about a whole bunch, the spinal cord, which obviously is the vertebrae, the discs, and the actual nerves themselves going through it, the spinal cord. And it is the central trunk of the entire body. All of the most important information, only all of it goes through that.
So I would like to petition that we move the brain to the chest, the heart further down to the stomach, and then all we have up top is just the eyes.
It wouldn't be a terrible idea.
That would be like a crab.
There are some interesting designs out there for life that sometimes make you go, that's not a terrible idea. But so you have all these things going through there. So you have a bunch of complications that can happen, right? So hemorrhage being one of them. Like, those 4 opportunities for blood either going up or coming down. Like if that gets opened up, very much bad. Airway obstruction. So if those things get opened up, the blood pouring into the trachea, that's a problem. Or just things in general getting stuck or closing the trachea, collapse.
Trying to eat and breathe at the same time, thus blocking.
And plus you have all this, like there's other tissue in there, like the voice box, the Adam's apple, that whole area right there, all of that cartilage and cartilaginous tissue, like that stuff can collapse. And if it collapses and it breaks, that gets in the way of the airway, can cause other problems too. You can have the actual spinal cord injury, like it getting, broken to the side or pushed off or swelling, causing pressure on it. And then one of the ones that we learned about, which we may have heard about before, but this helped solidify it, is the idea of like air embolisms and why those are very bad, and why, just to kind of roll from the things that could go wrong into the things that we do if we see injuries to the neck, like a possible air embolus or an injury to the jugular vein in particular. That's why we really we focus on putting on occlusive dressings to the neck. So like we don't necessarily pack wounds in the neck. We don't put pressure on the neck because there's so many things that can be collapsed.
Right. Like you have the ability to press on one side, not both.
Sometimes.
Yeah. And that there's a big caveat to that.
Yeah. Like you could, since you have two carotid arteries going up, if you put pressure on one of them, usually the other one will take up the slack. Like you could still have that one moving.
Right.
So if you have an injury on one side of the neck, you can put a pressure bandage usually on that one side of the neck, and then it won't compromise perfusion to the brain because you have the other side working. But it's to say that you still need to be very cognizant of the fact of where you're putting that pressure. But more so than that, like for things that could be an open wound to a jugular vein, you want to make sure that you're closing it. Just like you would for a sucking chest wound, because you don't want any air getting in. Because in that particular instance, the veins are a low pressure system.
Right.
Arteries are high pressure, right? They have that's why the blood's moving everywhere. Arteries have a low pressure and they're sucking the blood back to the heart. So if they get a hole in them, that can easily go and take in a bunch of air, and that air disrupts the flow of blood and causes an air embolus.
It's almost like you don't want the air where the liquid flows.
Yeah, that's bad because air doesn't go through the pump.
No,
it doesn't push anything, and there's no red blood cells in air.
Exactly.
Although you would think that it would just be like, we're just giving oxygen straight to where it's needed.
Again,
but nope, it doesn't work that way.
Back to poor design. If there's an alternate way to get oxygen in, use it.
Yeah. So we rolling into things that we could do. Yeah. Occlusive dressings for the neck.
Yes.
Sealing the wound, controlling the bleeding gently. Like if somebody has a wound in their neck, it's probably better to put a dressing over it than it is to like pack it like you would in other parts of the body. Like same thing for like wounds to the abdominal cavity. You can't really pack them. You'll be packing them for days because there's too much space in there. Same thing with the neck. You don't want to put stuff into the neck because it could close off and put pressure on, say, things like the trachea, the things that you don't intend to do.
Exactly.
Making sure that they are getting oxygen and supplemental oxygen if needed, and getting them rapid transport, all while looking for things like distress and cyanosis, the things that we're typically looking for, or things like swelling and deformities and stuff like that on the neck, which, would really indicate like there could be a problem.
If the neck's going like this, you should be paying attention to that fact.
Yeah. And by this, he's using his hands to represent an angle.
Not straight.
Yeah. Necks are supposed to be straight. And that really leads us into like the kind of catch-all for if it's not one of those kind of like soft tissue injuries, it's really like that's when we should be considering the use of spinal motion restriction and specifically a tool like the C-collar.
Which we'll be talking about in Tools of the Trade.
Yeah, there we go. Tools of the Trade tonight. The C-collar. That is a huge consideration, and it's why it's important, why we should be assessing that so early in the process, like in our primary assessment.
Yeah.
That's one of the things that comes so early. It's like part of the scene size up. What's our mechanism of injury? What are we considering for this patient? And should we immediately consider spinal motion restriction?
I mean, I think that defaulting to it is never going to be the wrong answer. Not necessarily defaulting to a C-collar, but defaulting to holding C-spine. Yeah. And when we talk about that, we're talking about using your hands to cradle the neck and the head together so that they're not moving independently of each other.
Yeah.
And if you can, putting them in a neutral position, assuming there's not contraindication that you don't want to be moving the head. You can always let go of it. If it's decided, okay, this doesn't seem like this is necessary, it can always be released. But
that's typically not going to be our decision, though.
It's not.
If you're putting in the effort to say, hey, I'm going to hold manual restriction, typically you're owning it until you can use some sort of device to do it for you. Because we're on the EMS side, we have those things at our disposal. If you're on the civilian side, it's a different story because like you may have to manage your resources.
But I don't think that if you have an accident, like a vehicular accident, or you have a nasty fall, or you have a nasty a mechanism of injury that makes you think that this could be an issue, I don't see how defaulting to that is a bad idea, except for the fact that your resources just got cut in half. Possibly.
Yeah, like having somebody have to hold it there. Yeah. So that's the nice thing about EMS.
Yep.
And our good, our sibling rivalry, if you will, with fire.
Yep.
And like, hey, you know what? If we need them, they come.
Exactly.
And it's super valuable to have that partner out there that's like, hey, we need some help. We need some extra hands. Usually we can call for, depending on where you are, it may take you a while.
Yeah.
But holding that manual C-spine can be something that's like, all right, we own this now, and we gotta hold this until the rest of them get there. But yeah, so it's super important to consider the manual restriction. But yeah, so why don't we talk about, so we talked about the neck, right? Let's start moving down, because the neck is part of the spine, right? Like what really, why is it important?
I mean, really is it? I mean, all it does.
Really is it?
All it does.
All it does
is carries messages between the brain and the body. I mean, come on, simple.
Yeah.
It's straightforward motor signals, sensory signals, autonomic control. I mean, all these things that are just the building blocks of the fact that you're a living thing.
Yeah, all your vital signs are basically determined from your spinal column.
I mean,
in some way, shape, or form.
Yeah, and the big thing is that injuries to it can cause permanent paralysis.
Yeah, that's why. Well, one of the reasons, because we don't want people getting worse, but the really the one of the reasons we hold that manual C-spine, or we use spinal motion restriction, is so that we're not making it worse. Same thing as we were talking about with splinting. We're just, here's the long short of it, guys. It's whole body splinting.
Yes.
That's essentially what we're talking about here.
Yes.
If you want to really simplify it, it's the same story. Like if there is a possible injury that can get worse, splint it.
Yeah.
And just splint the whole body.
Yeah. Make sure you're not doing more harm through the splinting.
Yeah.
And hold restriction on it so it can't do more harm.
Well, I will say though, and we'll get into this in terms of like the decision-making process, especially nowadays with spinal motion restriction, is it may not be as easy of an answer as splinting a long bone in an arm. Because that's very much like, hey, if there's a suspected break or fracture in there, splint it.
Yeah.
No question. Just splint it. Whereas nowadays with whole body splinting or spinal motion restriction, it's a bit more nuanced.
Yeah,
I would say the default is actually probably moved more towards not using a full body spinal motion restriction, not tying people down to a backboard. However, to your point, if there's a doubt, like we've gotten more educated into what should fall into that category, but if there's a doubt, I think it's still best to kind of default to like, hey, this won't make them worse in the injury.
Right.
It has some significant downsides in other patient aspects that we'll talk about, but as far as the possible traumatic injury goes, you're less likely to aggravate it or make it worse. So yeah, like all of those things travel through the spine. Yeah. Like the sensory stuff. And those are the signs and like that's how we know there may be some problems with the spine, right?
Exactly.
But we should always, like the things that we should, or the reasons why we should really consider spinal motion restriction is like, there's a few things.
Yes.
Biggest one being, and this seems like a catch-all, is the mechanism of injury.
Well, it kind of is, but the reality is that's part of that assessment, that initial thing of like
the scene size up.
What happened to them?
Yeah.
It could be something as simple as I tripped on a curb and fell, or he fell off that 20-foot ladder.
Right.
Like, so you have to, it has to be that immediate scene size up as you roll. You should be, if you can, like figuring that out before you get out of the damn ambulance.
Right.
If possible.
And having a threshold, and most systems will have like in their protocols, like this qualifies for this. Like a fall from this height equals a traumatic or a trauma response of X, right? So that's super important to know what those are, because if a fall from 10 feet is your threshold, well, then the answers are there for you.
Well, that means what you should do is you should get out your tape measure, your EMS tape measure. Well, I don't know. This is like 9.8 feet.
Yeah.
Or you should just
But is it a significant mechanism of injury?
Right.
Is it a fender bender, or is it a major car crash?
Exactly.
You know, like what were the other injuries involved? What speeds were involved? You know, was there complicating factors where if somebody fell off the ladder, did they fall onto grass
or concrete
or an uneven surface?
Yes.
Or a staircase, you know, all of these things come into play. Another thing to look out for is that altered mental status,
right?
You know, like in that injury. And this is where bystanders or loved ones can really come into play, because some people are a little spacey, you know, in general, but hey, is this person acting correctly?
Is this normal for them?
Is this their baseline?
Yeah.
So assessing the altered mental status could be huge, because that's, you know, sign of you know, could be intracranial pressure, other head trauma problems.
Which going back to previous episode, that's why you check blood glucose. Because if you don't have that person to tell you if this is normal for them or not, you can rule out the fact, well, no.
If they are exhibiting symptoms of altered mental status or like stroke-like symptoms for our state, yes, we can do that. But it's not enough. Like I had a call where I was rightly coached away from doing a blood glucose check, even though it was a patient with a history of diabetes, because she wasn't altered. She was not exhibiting signs of either altered mental status or or stroke-like symptoms.
Gotcha.
She had fallen, which may have been a balance issue. I took it as like, oh, well, maybe she's having weakness and symptoms of downstream from diabetes, because she had I had asked her like, hey, when was the last time you ate or drank anything? She said, oh, well, yesterday afternoon, and it was like the morning after. I'm like, well, that could be that, but that's not our protocol, right? And she was fine. Like she was with it. She wasn't having other mentation problems that could come from a low blood glucose level. She may have had low blood sugar, but that wasn't the emergent factor, right? So it's kind of like, oh, well, it could be an issue, but is it the issue that we should be worrying about? So yeah, that was an instance where like the paramedic I was with was like, we don't do that for that, because it's not our protocol.
Got it.
On the BLS side, right? So those things come into play. But if she was exhibiting altered mental status, hey, let's do it, because that could have led to the, you know, it's either a downstream effect from the traumatic injury, or it could have led to the traumatic
exactly.
injury. The big ones, the easy ones, head injuries.
Is the head look like it's supposed to, or is it bleeding or shaped wrong?
Right. Yeah. Like, and that's an indication of whether or not somebody should have spinal motion restriction.
Does the windshield have cracks in it because they decided that they wanted to try and put their head through it?
Right. Although that's a bit more of mechanism of injury than it is the actual head injury, because we're talking about the signs on the head now, right? So the bleeding, the lacerations, contusions, hematomas, the things that we might see on the head itself. Or you know, injuries to the eyes, nose, mouth, and all that stuff. You know, are they having pain? That's probably one of the easiest ones.
You mean asking a simple question of like, are you in pain right now?
Well,
yes.
Or not just, are you in pain right now?
Where?
But does your neck hurt?
Yeah.
Like, oh, it looks like you fell and bumped your head. What hurts?
Yeah.
Well, like the top of my head kind of hurts, but everything else is fine. Feels perfectly fine. Okay. Well, that is I had some experience today where that was the primary determination for, well, that's the leading indication that for us not needing to do spinal motion restriction, because while she had a head laceration from a fall,
everything else was fine.
There were no other signs pointing to whether or not would it have been wrong to do spinal motion restriction? No. We could have done that. It would have been easily justifiable. But is it also easily justifiable to say it's an unnecessary intervention for that patient to put on a C-collar and go through that process? Yes, because she had no other indications for an injury from that fall.
And you're not going to cause more stress to a patient that doesn't need it at that point.
Right. And then, of course, the neurologic deficits. So are they having CMS? Like, this is why we check for CMS, because it's not just for pulse sensation. It's also for the neurologic effects of like, can you feel your extremities? Can you feel me touching your hands? Can you push with your hands? Can you pull with your hands? Can you push with your feet? Pull with your, like, you know, what's their motor sensitive?
And are they equal?
and are they equul, right?
Yeah.
And that's a huge sign of whether or not that somebody might have damage in their central nervous system. But what can cause it? Like, we're obviously those are the things that go wrong, but what are those mechanisms of injury that could cause these types of things?
Well, if the vertebrae shift abruptly, you can pinch, you can cut off the spinal cord, you can pinch the spinal cord.
Sure, yeah.
You could have a large amount of swelling, which is also causing it. You have numbness and tingling, which is not a good thing.
Yes.
Weakness, like you said, paralysis, loss of sensation, breathing difficulty. Like, these are all things.
Right. But what more so than what we're seeing in the body, what are those mechanisms of injury? Like, what are the things that could happen to a person that make us suspect? Like, we talked about a couple of them, falls,
right, or
one, but what else? Like, what are those other big things?
Well, I mean, the biggest thing, I think the most common thing is like an auto accident.
MVAs, right? Yeah. Like, that is spinal motion restriction, trauma 101.
Because when you come to a sudden halt,
everything keeps moving.
Your head keeps going.
Yeah.
Just because your chest was held tightly by that seatbelt, nothing's holding your head. It might be hitting an airbag eventually, but it's not going to stop moving.
So MVAs, falls,
diving injuries.
That was the big one when I was a kid. Like, I remember so many stories of kids, and I was in the Scouts too, and like that was a very large focus of like the life-saving program. Like, because I did a life-saving merit badge at one point, and like there's a lot of stuff in there about spinal motion restriction in the water, where
it sucks.
It's not easy.
No,
but like you have to do that because you get things like diving injuries where you dive into shallow water and crack your head.
I've never understood that. Whenever I've ever dove into anything, my hands always go first.
Yeah, but just because your hands are first doesn't mean that your arms can't collapse and your head still hit the hard thing.
I guess.
Well, the problem is that there is such a thing as a shallow dive and a deep dive.
Yeah.
And you're not stopped. Like, if it's shallow water and you're doing a deep dive, you're not stopping yourself. Like, your arms are not going to stop you.
I did it once and it did not feel good.
Okay, cool. You're like the He-Man who is able to stop his own body weight from falling and cracking your neck apart on the ground because of your arm strength. But like, typically, that's why it happens, right? Like, your arms just can't support that, even though they're in front of you, or that you may miss. But like, there are shallow dives, there is like shallow water entry and all that stuff. But like, the diving injury is like that kind of classic example of, they hit the head, their neck so hard it turned sideways, and now they're paralyzed in the water, right? Which adds a whole bunch of other factors. Is like, you can't breathe in water, so that's a problem.
And if you can't move and you're in water and you can't breathe in water, this adds up to bad things.
Yeah.
And then you have sports injuries.
Sports injury, I mean,
which is huge.
Yeah, it's like motor vehicle crashes, like bodies in motion crashing against each other, causing trauma. Like, it's the same thing.
Yeah, yeah. Like that guy that spears his helmet into the receiver's chest. Like, well, there's going to be reciprocal force going back into his neck.
Yeah. You got like some of the other things though, like violence. That can be a big one, especially like fighting, like even like combatives, hand-to-hand type stuff, like putting pressure on the neck and spine. Things like explosions. You might get like anytime where that body's being pushed in one direction super hard, super fast. That's going to lead to possible, spinal injuries. Anytime things collide, that's really the thing to look out for. But as it comes around, the mechanism of injury, that's the thing that we're looking for. That's really a story here for spinal motion restriction. Like, you should be assessing that with a keen eye to say, like, is this like, should I take the safe route and use spinal motion restriction, even because like they're not showing signs. But like the mechanism of injury was so great. They fell from 25 feet.
You should assume.
You should.
I think
it's
you
like,
have to. You have to use that detective brain of saying, okay, this might be an issue.
Well, it's not might. Like, this is so strong.
Yeah.
that is the determining factor for, okay, we're going straight to C-spine, even if there's nothing else supporting it.
Right.
Sometimes there's more of a gray area in the middle, which is harder to do, but like sometimes it's very cut and dry.
Yeah.
Hey, they're in a motor vehicle accident that was super bad. We're going to spinal motion restrict them because that's what we should do. Exactly.
And then you start talking about physical assessment for it.
Okay. Yeah. So what do we do?
What do you do?
Yeah. Well, it really comes down to I think we covered it 2 or 3 episodes ago, decap BTLS, right?
Yes.
I'm not even going to go through all the letters, but like the things that we're looking for are the deformities, the things out of place, are bruising. The one thing that is the key term here for the spinal stuff is step offs.
Correct.
So you have, what was the little bumpy things called? I thought you had that term before.
I did.
Spinous process or something like that.
Yes, I believe.
The little bumpy things.
Yes, little bumpy things.
The bumpy things on the vertebra.
Yes.
So when you're looking and you're assessing the back and you're palpating it, if you feel one of those ones and they're bumped out a lot farther than the others, or you feel the whole, or in or whatever, that's called a step off, where it's kind of like, it's creating the shape of a step. And that's your vertebra being out of alignment with the other ones.
Absolutely.
Or a 90-degree bend where it's not supposed to be.
Or like, are you hurt? Do you have pain somewhere? Yes, it's in my neck. Mm-hmm. And then using that to guide your assessment. Yeah.
Like the tenderness when you're poking around places, if they're feeling extreme pain when you're putting, when you're palpating the spine or the neck, that's a sign. They may not feel it until you do that. So that's important. It's why it's important to put hands on our patients for those those trauma assessments.
And you got to get eyes on too, and you got to be able to see if there's bruising, if there's swelling.
Yeah, you got to visualize it.
So yes, you should be using your hands. You should be using your eyes as well. That's the whole idea of getting that area uncovered so you can see what is going on.
And we got to do a neurologic exam.
Absolutely.
Like that's because there may not be things seen, but there's downstream effects that we can see from trying to have the patient do things. Like, hey, do you feel me touching your hands? Mm-hmm. What finger am I touching? Do you feel me touching your feet? Can I feel their pulse in those extremities? And then really one of the big ones is having them give motor function, give resistance. Like, hey, push with your feet or pull up with your feet. Are they having, do they have strength in them? Is it weakening? And is it the same on both sides? Like, do they have bilateral strength?
Exactly.
So that's a big one. And that can be very telling, and making sure that you're getting both sides at the same time. Mm-hmm. It's not a one-sided story, even though they're like, oh, my one leg hurts. Okay, let's do both.
Yeah.
I realized today that I screwed up on that. I had a call earlier and I realized just now that I was like, I never did the other foot. I just did the one that she was, the leg she was complaining of. We learn things all the time, guys. It's a process.
Yes. It's practice.
I don't mind telling you all the things I do wrong, because we all do things that are wrong. Hopefully we do small things wrong often instead of large things wrong often.
But I think there's a huge value to that in what we do with this podcast, is that we're pointing out the things that we're missing, the things that we realize later on, okay, I should have done that better.
Yeah.
Because that means maybe you, the person watching, listening right now, may get to that assessment and realize, oh my God, that's right, I need to do both.
Yeah. Yeah. It's, it's about the reality, guys. Like, there's a lot of, in my experience and trying to look for media and things to help me learn about EMS, there's a lot of polished stuff.
There's a lot of it. Yes.
Where it's very kind of like, educational, and it's like they have to be perfect because they're holding it for posterity. We have the luxury on this podcast of kind of explaining our learning process and how we're going through it. So part of that is being wrong and understanding when you're wrong and then correcting it. And it would be a disservice if we did not highlight those opportunities.
I think there's so much value in that. That personally, I think there's more value in that than that polished exterior that you see on some.
It is.
Personally.
Yeah. I mean, like, if you're just absorbing from a learning standpoint, those can be important too. Mm-hmm. But if you're looking for the experience of like what it's like to actually go through the process and like how was it to learn?
Mm-hmm.
And if you want to learn from the learnings of others, I think you have to be vulnerable. Like
Right.
that's one of the things I've felt very strongly about on this podcast is like, I don't ever want it to come across like I'm like, I know everything.
Right.
Like, or that any of us are like, you know, deities in the space. Like, oh yeah, we're perfect. It's not a perfect industry.
It's not.
People make mistakes. The thing is, we're partners for each other. We back each other up and all this stuff.
Mm-hmm.
We're getting deep into this.
We are indeed.
Yeah. So we're where were we talking about? Where's the how to assess, right?
Right.
So,
and then there's certain functions dependent upon the location of injury. There's certain,
and that can be telling about where the injury
Sure.
is. This is like the difference between. Okay, I'm going to use some pop culture references that probably nobody will even remember. So it's the difference between the Tom Cruise's character in the Born on 4th of July, who is paralyzed
from the waist down.
probably from that would be lumbar
Yes.
injury, probably. Yes. So he's paralyzed from the waist down versus a Christopher Reeves.
That is the classic.
Yeah, like quadriplegic.
Cervical,
cervical collar, cervical spine injury.
Yes.
Where he was a quadriplegic and he had to be on a ventilator. Yep. So like everything from the neck down no longer functioned on its own. So like depending on where that injury is on the spine can determine what parts of the body are affected.
Right.
And usually it's like, is it everything up top? And like how far down is it going? Like, does it affect the lungs or is it just the arms or is it the digestive? I don't know if digestive system can be affected by.
I'm sure it can.
I'm sure. Yeah. But yeah, there's or bladder control, like all the stuff in the hips, like the sexual organs, the bowel control, all that stuff winds up getting affected at different levels of the spinal column.
Yeah.
Yeah. But yeah, so, really what it comes down to, and this is just a kind of quick recap, I think, is what are we looking for? Like as BLS providers, if we're suspecting the, like if we see a possible mechanism of injury that could be, something that needs spinal motion restriction, we're doing our primary assessment.
You have to start with the ABCs.
Yeah. Airway, breathing, circulation, done. Okay, we know that.
Yep.
We've probably said it far too many times. But we're also in that initial assessment, that scene size up, saying, should we be providing manual stabilization?
Yes.
And using some sort of tool or adjunct to provide permanence, or not permanent, but like, stabilization without us having to hold it manually, right? The C collar, a splint, or placing the patient on a longboard. Right. We should be asking some questions in the interview too.
Sure. Like, do they already have a history of back injury?
Yeah. In that secondary assessment, as we're going through and looking for stuff, what has happened in the past? Because
you may have an injury that was aggravated that they had already.
Yeah. Like my back, your back, my back. Like, those are things that are important to ask about. Like, have you had trouble with that part of your back before? Because it may not be related to the mechanism injury of today. It may be from the past.
Like, as an example, if someone came to me right now and started squeezing my toes and saying, do you feel this? And I didn't tell them that I had neuropathy, which is a chronic issue with your nerves, where you have lack of sensation, you have that pins and needles feeling.
Yeah.
If they don't have that history and I don't give it to them, they maybe immediately thinking, oh my God, what's happened?
Right.
Whereas it could just be, I have neuropathy, which is why I can't feel what you're doing.
Exactly. It's exactly like, it's really important to get context for the things that you're seeing, not just, and then, that physical exam, everything we talked about, what are we looking for? We're palpating, we're touching, we're making sure that we can feel the injuries. We're looking for the step offs, the deformities, the things that could be, visual and or palpable signs that there is a problem.
And assessing motor strength.
And,
is it bilateral? Assessing sensation. Do they feel what you're doing? Can they feel what you're doing? Can they tell you like what finger you're touching or what toe? And then obviously checking the pulse.
Yeah.
At the distal points.
Yeah.
Like, do they have proper circulation to the area?
Yeah. So that's really what we're doing here, right? Now, here's the crux of this, and the thing that we've been alluding to, and we'll kind of just hit on it here because we've already touched on it.
We have.
Is like, what is the modern, and like this is where we wish Jonathan was here, because he's been doing this for 15 years, or even somebody like Bob.
For sure.
Bob Waddell from Sam Medical. I think he would be an amazing person to talk about this with, because he's seen an entire transition of, or he's seen the kind of evolution of spinal motion restriction since kind of the beginning of EMS. Mm-hmm. But even over the last 15 years, there's been huge changes that we've learned about in school. People have told us about, because they used to do things much differently than what we're seeing now as fresh EMTs. Yeah,
it used to be routine for them to put you on a backboard and strap you the hell down.
Every time. Even whatever the mechanism injury was,
strap them down.
C-collar, strap them down to a backboard.
Yep.
And transport them.
Exactly. That's it.
Yeah, like everything. Right. That makes so life easy,
right?
Yeah.
Yeah.
Your stomach hurts, strap them down.
Yeah, cold. Okay, strap them down.
Heart attack, strap them down.
That's it.
Straight to jail. That's what it reminds me of. But it used to be simpler, right? But what did they find? Like that's that, and like this is the thing that really calls out to me, that hits for me.
Yeah.
So was the using the backboard in making the primary injury worse? No. However, what they were finding, this is what we've been told, like using those backboards led to other soft tissue injuries. Like
I can tell you from experience, being strapped to one, it's not comfortable.
No.
Like my back was killing me when I got off that thing, because if you look at a spine, it's got this natural curvature to it. Well, this is a flat piece of plastic.
There's no curve in a backboard.
So like there are definite downstream effects. Plus, if you're trying to not stress out your patient, I guarantee you strapping them to a piece of plastic is not going to assist with this.
Yeah, they don't like being in like a comfy stretcher that has like a recliner.
Yes.
They don't even like that. But
so they sure as hell aren't going to want to be strapped and immobilized to a piece of plastic and then carried around.
Right. But I think what we've like, what's easy to understand with that is like, imagine laying on a concrete floor, right? And then having somebody put weight on top of you. Mm-hmm. Not so much that the weight hurts, but just so that presses you into the ground. Yeah. You're going to develop hot spots. You're going to get pressure points, like where you're like the backs of your hips, those pressing on that hard surface, your shoulders, your scapulas, the areas of your back that are meant to be curved, that are having pressure to try and straighten them out. Your knees being hyperextended. So all of those things led to secondary injuries happening from kind of doing a full body splint, right? So then the industry had to look at that and go, well, what's more important? Like, what are we inducing more pain and discomfort in patient care? And is that worth the chance? And it's not an easy answer.
I think it's a very subjective answer. Again, it goes back to that mechanism of injury. Like, what has happened?
But it's not to disagree with you, Max, but is it subjective from our standpoint? Maybe. Like you have to use our best judgment on what injuries qualify instantly for spinal motion restriction. But statistically, like as a whole, the reason why this whole debate has been happening is because they look at that and go, hey, the numbers point to
it not being
so subjective. And like, okay, if we have this method that we use time and time again over the course of time, we can go, hey, like 80% of the people, I don't know if these numbers are correct, but I'm just saying, like, this is an example. If 80% of the people that we strapped to a backboard wind up having secondary injuries or discomforts, and only 2% actually needed to be tied to a backboard. We're now over-indexing on safety with the downstream effect of
causing more harm.
Right. So it's like, okay, we need to look at that and adjust the way that we're approaching it, right? So that's why the industry has changed. And what it's changed too is kind of what we're seeing now. We have to assess. We get to use our brains, and and we have to see how it's going. But I mean, the solace, the thing that we can always fall back to is like, if the mechanism of injury is significant, if there's any indication, it's still okay. It is okay to default to using a backboard and use. It's not like a compulsory thing where every single time you have to do it anymore.
Exactly. Yeah. Which is, by the way medicine should be in general.
Yeah. And honestly, from what I've seen, like in injuries where somebody like traditionally would be like needing or be given a spinal motion restriction, and they haven't been, vast majority of them wouldn't have needed it. Right. Like they were perfectly fine. They had no indications of needing a C-collar or spinal motion restriction, and it would have just made them discomfort. It would have given them discomfort. Yeah. So, I think it's a good move for the industry.
No, I think no matter what, I think just having like this automatic response of 1 + 1 = 2 without the thought of anything else is a bad move.
Yeah. Couple of things to talk about, I think, before we kind of get out of this section, because we've talked about a bunch of things, and there's like different topics that that we were brought through in this chapter. The things that we use, we're going to talk about one of them, the C-spine, the C-collar.
Yep.
We've talked about backboards. KED boards are a thing. That's like half body restriction, usually used for a seated patient getting out of a car, used in conjunction with a backboard. So like there's all these different types of tools.
Right.
Like on the backboard is those head blocks that keep the head from moving. So all of those things used in conjunction to create that kind of restriction, right? That stabilization. So we learned about a bunch of different things there. The decision making, we've talked about that a bunch in terms of like what are the factors coming into this process,
right?
You know, I think the thing that we should probably talk about that we haven't really hit on, which was an interesting point for me because I'd never really thought about it, is, you know, obviously, we should talk about two things. We should talk about backboards, the proper way to like when you go through EMT school, I'm not going to go too deep into how to put somebody onto a backboard and what the process of doing a log roll, because it's very much part of the curriculum.
And it's very much, I think, something that it's about doing it.
Yeah. And like it's a physical skill.
It is 100%.
But it's important to know the right way to do it because
100%.
Because so many people we saw from like, you know, as fellow students, they're either smaller people or they're not as comfortable like manhandling a human body. But that's really an instance where you need to be able to roll somebody onto yourself and roll somebody back. And like, you don't want to half step stuff when you're doing a log roll, putting somebody onto a backboard if they need to be on a backboard. So that's important. Learning the right way to kind of immobilize them, put them on there while securing them for transport and doing that. And then especially working as a team.
That's the big thing.
Yeah. Like that is huge.
When you do the log rolling onto a longboard, it really is critical that everyone is doing the same thing. They have the same idea of what's going to happen, how they're going to do it. Even to the point of moving a patient once they're on the longboard. Like you have to have that coordination as a team, moving as a team. It's critical.
Yeah.
It's critical.
Absolutely. Like you all need to move together. Some of the other things in EMS, you're working as a team, but you're all doing individual stuff.
Right.
When you're moving patients, that has to be one mind, one body. Like you are all moving together because that can, oh my God, that honestly, moving patients has been the one thing where I'm like, this feels so dangerous sometimes. Because if one person slips, that patient can fall off the side of the stretcher.
Sure.
That stretcher can tip over. I've seen some of the terrible videos of like,
oh my God, yes.
like moving a stretcher sideways. It's burned into my head. Never
do that.
That thing never turns. Never moves sideways.
Yeah.
Unless you're pushing it up to the hospital bed. That's the only time it can move sideways.
Yes. Otherwise, because that is a completely controlled floor, smooth, level. But yeah.
But it's also the only way to do it because you have to roll it in and then push it up against the hospital bed. But
even there, just getting someone off a stretcher.
Yeah.
Like someone's got to take charge. Someone's got to be in charge of the count of what we're doing.
Yep.
But everyone has to understand as a team what's going to happen. And if you're not communicating what it's going to be, it's a mistake.
Yeah. So like longboard moving, like a reef stretcher moving, it's all really the same. I think the longboards are the worst because you're basically all the weight is on top of the thing that you're holding. So it's very tippy.
You would think that someone being strapped to it would make it more stable, but it really isn't because the center of gravity is so high.
Yeah. Like your center of gravity is below where you're gripping things below where all the weight is. So it's so easy for that thing to tip sideways and all of a sudden the patient gets dumped on the ground face first. And it's has to be like, and put more people on it.
Yeah.
Like if you can put everybody you can on it, there's no need to only have like, 2 people on moving a patient. And there's different tools too. Like we learned about, we've talked about them before on the podcast, like the scoop stretcher, learning how to use that versus a typical backboard, especially with cases of, possible spinal injury can be a huge game saver for not moving the patient more than they have to. You don't have to log roll somebody.
In case you don't remember, what the scoop stretcher does is it basically comes together under the patient.
Yeah, scoops them up.
Yeah, and our friends at SAM have a combo. It's a backboard that comes together under the patient.
The combi board is sweet. It's I'm like, oh, why aren't they all like this? Because it's the end result is a backboard, like it's like a typical backboard, but it comes apart and works like a scoop stretcher.
Exactly.
So it's like, why would you need to? Because a lot of ambulances carry 2 separate things. Anyway, I love smart design stuff.
Sure.
Sam does. Shout out to the guys at Sam.
Awesome.
They're really good people. But yeah, so learn how to do the right things, use the right tools. We're going to talk about one of them terms of the C-collar. The last thing I think we should chat about, though, before we move on to our tools of the trade is like the instances where somebody may be wearing a helmet. Because like if we're doing a standby at a sporting event, motor vehicle incident involving a motorcycle, anything where somebody might be wearing a helmet, it's important to kind of know that like there are rules that you should follow with that.
I think the biggest thing is if their airway is not being compromised, if their airway is clear, leave the helmet on.
Yeah, that's pretty much the rule, right?
Right. I mean, like, because no matter what you do with a helmet, unless it's something that's fitting very loosely, you're going to be interjecting movement of the head and the neck, which is what you're not supposed to do. Some of the newer helmets for motorcycles, even with a full face mask, the face mask comes off. Which
it comes all the way up so you can get access to the chin and the mouth.
So you could put a C-collar on and then maybe remove the helmet. But if they're breathing okay, their airway is clear, it is not compromised, leave the damn thing on.
Yeah, and really, like if you're considering using spinal motion restriction, while someone's wearing a helmet, use the helmet to your advantage if you can. Like if it's undamaged, if it's not going to cause any additional problems, that helmet could be the thing that keeps their head in line, and you could tape that thing down to the backboard and use that as a form of stabilization too, if appropriate, right? Like if it's putting the body in an unnatural position, don't do it. But most of the time that'll allow you to kind of, okay, we're going to tape down this helmet, make sure it's not moving around, and that will help stabilize the patient. And then being able to put a C-collar in there is the bonus. Like you should be able to get a C-collar under a helmet. There's really not a lot of instances where you wouldn't be able to if you're doing it gingerly and like in the right way, because you shouldn't be moving the head to do it anyway. And helmets don't usually go down to where the neck is, but that could be a thing that happens. Yeah. Right. So the helmet can help stabilize them. And like you said, if it's not compromising the airway, you don't need to take it off.
No. Let the hospital deal with that.
Yeah. Or in some strange instance where it's causing additional problems, obviously, then it's like, okay, we can remove it. If you do need to remove it, it's not a one-person job.
No.
You need somebody to reach up under the helmet, hold the head still, and hold manual stabilization while the other person gingerly and gently removes the helmet. Because the whole point of helmets is they are not loose.
No, they need to be tight.
Yeah. So it's very difficult. And if you need to remove parts of the helmet, if they have chin straps that's why, I like football helmets.
Yeah.
The face mask opens up and you could take out the cheek pads and stuff.
Right.
You could just reach in, pull those things out, and then that'll help removing the helmet and stuff if you need to. But otherwise, just take that the front grill off and then have access to the head, to the face. So I think that's everything. We've gone through a lot. The big one here is in the assessment and the decision making.
It's everything. Figuring out what is going on, paying attention to how it happened, how it may have happened, and then doing that physical exam past that and asking them the questions like do you have pain? Doing that motor assessment, doing the sensory assessment.
Yeah.
This is
sensory
huge.
motors. I think probably the one that I need to focus on it more.
I mean, and really any kind of orthopedic injury, this is also one, that's part of it, whether it's the arm, a leg, an ankle, a head, a neck, you're using that for every one of those.
Yeah, exactly. Yeah. So there's a lot of things in here. I think this is a good kind of, I like this stuff because it's the things that we're going to deal with every trauma.
Yeah.
Head injuries, not always every trauma. But the consideration for spinal motion restriction, for manual stabilization, every time someone's going through a trauma, you should be having that run through your head of, should I be doing this? First thing.
Yep.
Obviously, life threats. That's first because it doesn't matter if they're...
you let that go. Eventually that'll solve itself, and then you have an easier package.
Yeah. But you solve it doesn't matter if their spine's messed up if they're not breathing.
Yes.
Right? We need to fix that first. But in that initial assessment, we should be going, do they need spinal motion restriction?
Exactly.
But that leads us into
our tool of the trade.
Probably, the most used tool when it comes to spinal motion restriction, because if you're going to put somebody on a backboard and do full body spinal motion restriction, you're doing this first.
Yes.
The C-collar.
The C-collar. So what is it? It is a rigid plastic device that has an adjustable chin strap, so it adjusts for different heights of neck, and it uses Velcro to basically hold itself shut, and it immobilizes the patient's head and neck.
Yeah, it's a splint for the neck.
Exactly.
It holds it in place, and it conforms to the anatomy to essentially not let the neck, which is super... Again, super bendy.
Back to my point of poor design.
Yeah, super bendy. It doesn't allow it to go forward, back, or turn left and right, essentially, right?
And we learned through applying these repeatedly in class that when you don't have it on right.
Yeah, because you can move your head.
You can move your head. And there's a couple different ways to apply these. There's a couple different methods to it as well. There's a classic one where you basically pass the back half of the C-collar behind the neck, and then you bring the front around and you meet on the side where the Velcro is after you've already adjusted the chin for height. The way you figure out how to adjust this is you take your fingers and you measure between your trapezius muscle and your chin, and however many fingers that takes, you then line that up on the side of the C-collar, and there's these little holes.
Well, let's just, not every C-collar is going to be exactly the same.
It's not.
So our example here is probably the most prolific that we've seen, which is the Laerdal stiff neck. Although this one's an older model, so I don't know if that's still the same. But Laerdal makes probably the most prolific C-collars. But there's other ones too. There's softer ones, or there's some that are more nondescript, almost like generic C-collars. And then we're not going to go too deep in them because not a lot of nobody really uses them in EMS. is like the soft C collars.
Oh yeah, the classic,
like the foam thing. Like the guy, is trying to get a lawsuit, and he walks in with like a big foam neck pad. We don't use those.
No, we don't.
No, I have not seen anybody use them. But like that's also a form of C collar. It stabilizes the neck, but it doesn't immobilize it. Like it kind of like, I guess, gives resistance, but it's not the same thing.
It's not the same thing.
But the rigid ones typically, if you're looking at them as a procedure, they usually have a height adjustment,
yes,
which you have to learn based off of that tool,
which is tough.
And it has a way of closing,
yes, that
you need to be familiar with.
Yes,
like that's really what it comes down to.
That's what it comes down to.
Yeah,
and there's different methods on how to apply these. The main thing is what you're starting with is manual mobilization. Like that's the start.
Yeah, because you're not going to just go straight to the C collar. You're gonna probably have somebody holding, and then you're going to put the C collar around in the neutral position that they're already in.
Exactly, and this may be contraindicated, but if it's not, you're holding manual stabilization, and then you're using this tool because this is taking the place of your hands during that manual immobilization. So there's different sizes. There's pediatric sizes. There are adult sizes. So you have to make sure you have the right size. Once you've found the appropriate collar, again, measure that distance between the trapezius, which is the muscle up on the top of your shoulder, and the bottom of their chin. And you basically use finger widths in this model anyway.
I will say, to me, finding the correct height of the device is the hardest part, because every time I've done that kind of like finger method and trying to figure it out by like it's always too short.
Yes.
Like as a default, I think people think like, oh, it's supposed to fit in this space under the neck instead of it necessarily pushing up and down on the chest and the chin at the same time. So they tend to undersize.
Yes.
I know I have. So really it's like, yeah, that can give you a rough estimate, but if it's not doing the job, that's the most important thing to figure out. Like, is it putting pressure, not excessive pressure, but is it stabilizing the chin? And is it touching the sternum area as it's laying on the chest? And is it like hitting the trapezius muscles, the shoulders, and preventing the head from moving? Because if there's any gaps in there, it's not doing
its job.
Yeah, I mean, it's not a necklace; it's a collar.
And here's the thing: we all had it applied to us. It's never been comfortable.
No,
not once.
I mean, it's not uncomfortable,
but it's
like
it's
not painful, but it's certainly not enjoyable.
No, not at all.
Because if it's done correctly, it doesn't cause pain, but it certainly keeps your head from being able to turn and move forward and back whatsoever.
So again, like he said, there's different models, there's different variation. This is the one that we've seen. I haven't seen the other types. This is the only one I've seen it in.
They're all very similar.
They're all the same.
Yeah, like sometimes they're just different colors. Essentially, it's a rigid plastic frame with some foam.
Yeah. And make sure you have the right size. Like if you have a child or a small female, like you may have to go to a pediatric.
Every BLS or every ambulance needs to, I believe by protocols, needs to have different sized devices. So obviously an adult one won't work on a child.
And its history. So origins and early development. Initial invention was in 1966. A guy named George Cottrell invented the modern cervical collar during the Vietnam War to provide neck stabilization for American soldiers with potential spinal injuries. So like a lot of things we've talked about.
It's all about warfare.
It's all starts in warfare. Yeah. And a lot of it
just
happened
like EMS.
In Vietnam.
Yeah.
Like a lot of it happened in Vietnam. The concept was originated in the 1940s and 50s, though, based on an anecdotal observations that moving patients with vertebral fractures could cause hyperflexion or hyperextension, potentially leading to paralysis. And then in 1967, Dr. J.D. Farrington, an orthopedic surgeon, popularized the pre-hospital use of C-collars in the U.S. through his influential paper called Death in a Ditch.
Death in a Ditch.
Death in a Ditch.
That sounds like the most metal album of all time.
It really does.
Like that was obviously in the top 10 Billboard charts for metal albums in 1970.
It should have been, and it may have been. I guarantee it's a song somewhere.
Death in a Ditch.
And now they're a one-use item. You use it once, you throw it away. Like most
they're
things
disposable.
in medicine. Formal recommendations happened in 1971. The American Academy of Orthopedic Surgeons proposed the use of cervical collar and longboard spine boards for patients with suspected spinal injuries, which we talked about.
Yeah, so it's like the proliferation of understanding, like, because the understanding of spinal injuries proliferated like in the 70s, like, as people learned more, they're like, hey, we should not let the spine move as much and we'll cause less problems. And obviously that thing became prolific.
And the fact that it's cheap, it's disposable, just makes it that much more popular on ambulance services, because it's an item that they're not going to worry about using.
Well, yeah. I mean, like anything that's now patient related, like, if it touches the patient, we've gotten to a modern material science that like pretty much everything is disposable. Yeah. Like there's no point in holding
whether good or bad.
Yeah. I mean, like those things I think cost like $5. Like, they're not expensive.
They're not. And again, like we talked about earlier, it used to be the gold standard, but that's being questioned.
It is, along with backboards in general, have C collars been overused in preceding years? And like, what is the right threshold for using a C collar versus not using a C collar? I don't think we're ever going to land on an exact science.
Yeah. The main questions they had is, does it really effectively decrease motion? And can it cause complications like increased intracranial pressure or pressure ulcers?
Interesting.
And those are like the big questions about, it's just uniform use.
I think, for most instances that involve a neck injury, it's going to be pretty clear.
Yeah.
Hey, their neck hurts. They have an injury to the neck. Let's put a C collar on.
Yeah.
And like, let's be safe. I think there's fewer downsides to using the C collar
than a backboard. 100%.
Yeah.
But yeah, there you go. C collar.
Awesome. So that's a good one. I think that's definitely one that we use often, that it's been kind of sitting in the quiver for a while for tools of the trade, that like, hey, there's not a better night to talk about it than
neck and spine.
Neck and spine is the C collar.
Exactly.
Cool. Thanks, man. So this is typically where we would kick things over to our, lovely learned paramedic who guides us into the student preparation side.
Where are you, Jonathan?
But he's not here tonight. So Max and I are going to do a couple of questions out of the Pocket Prep app. Because we want to stay current. Sometimes we get them wrong, but we do it for you. Really,
exactly.
We're gonna go through today's question of the day. We'll take our best stab at the answer. Hopefully, we'll get it right, because we've passed this already. But the rationale is the most important part in how you're thinking about it, and we'll go through that too. So
So the question of the day from Pocket Prep is, which of the following is a contraindication to oral glucose? So first is altered mental status. Second is unknown blood glucose level. Third is prior insulin use. Fourth is inability to swallow.
What is your confidence level on this question?
100%.
Me too. So it doesn't matter which one of us takes it.
It's not. But let's throw certain ones out the window.
Yeah, like, okay, I think that's a really good strategy. So which of these are contraindications to oral glucose?
So
altered mental status. Well,
an indication.
That's an indication for oral glucose. Yes. So we could take that one right off the board, because that's why we would give oral glucose is for a possible diabetic emergency.
Yep.
Unknown blood glucose level. Well, that is also not a contraindication. It
is not,
because if you're let's put it this way. What we learned in school was if somebody is suspected of having a diabetic emergency and they're having an altered mental status, or they're having other indications of like, a diabetic emergency, oral glucose is for low blood sugar, but
Correct.
if you don't have the tools available to know whether or not they have low blood sugar or high blood sugar, give them the oral glucose
It's
anyway,
not going to
because it's not going to exacerbate high glucose levels that much.
Yes.
Like it will obviously make their blood glucose higher, but those don't happen as rapidly, right? Okay.
And prior insulin use, again, the clear answer is inability to swallow.
Yeah, like prior insulin use. Of course, if they're diabetic, they've probably used insulin before, or they may not have. It doesn't matter.
And even if they never have, it doesn't matter.
Yeah, it's a non-factor. Yeah. So this one's 100% a lock. Inability to swallow, because if you're giving them something orally, they have to have the ability to safely put it down their airway.
Exactly.
Or to put it down their throat so that it doesn't get in their airway.
Because what you don't want to do is you don't want to make things worse. So if they do not have a clear airway, you cannot be putting things in their mouth for them to swallow.
You want me to take question 2?
Yes.
Okay. That was correct, by the way. The inability to swallow. Okay, so the next question for this evening. Which of the following measures is appropriate emergency care for an adult with an early localized cold injury? Placing hot packs on the suspected cold exposure site, submerge the affected body part in hot water to rewarm, protecting the affected body parts from further cold exposure, or have the patient vigorously rub the affected area. So this is one of those ones that's asking for one answer.
Yes.
Because sometimes they get tricky. I hate those. I hate the ones that ask for like 3 out of 5.
Mm-hmm.
They love those. So what it's asking is, which of the following measures is appropriate emergency care for an adult with an early localized cold injury? Meaning frost nip.
Yes.
Not necessarily frostbite, because that's not an early cold injury. Frost nip is kind of the pre-stages of frostbite, where they've gotten an extremity really cold.
It's usually white.
It starts turning colors, but it's not damaged, but it's on the way.
It's
right?
on the way.
Okay. So that's what we're looking for. So let's go through one by one. Are you? So I'm pretty much locked.
I'm going to throw away the rub vigorously.
Yeah, you should not rub things vigorously.
That like right away, like no.
I would also throw out instantly submerging the affected body part in hot water to rewarm.
Yes.
There are some instances and sometimes where you need to submerge a body part in water, but the answer is never hot water.
No, it's never hot water.
Sometimes it's lukewarm, sometimes it's body temp, but you never want to submerge any part of a body in hot water, especially something that's been damaged or potentially damaged by cold.
Yes.
So that one's
right out
the window. So that leaves placing hot packs on the suspected cold exposure site or protecting the affected body parts from further cold exposure. And that's actually, that's a hard question.
Because either one of those sounds like they could be right.
I would say that it's not inappropriate to place hot packs on the suspected cold exposure site, because that helps rewarm them, and it's a gentle rewarming. It's not dousing the hand in hot water. However, what it's actually asking is, which of the following measures is appropriate emergency care for an adult with an early localized cold injury? So it's the early aspect that I think is the key one here. Because you could rewarm body parts, or rewarm people with warm packs. That's what they're for. But for an early localized cold injury, I think the key thing being early is stop it being cold.
Exactly. Stop it from getting worse.
Yeah. So I think easy answer,
C.
100% lock is C, protecting the affected body part from further cold exposure.
I agree 100%.
Let's see if we're correct. And we are correct.
Nice.
For all the reasons that we just mentioned. Never place heating pads directly on a localized cold injury.
You should always have some kind of insulator.
Yep. Never attempt active rewarming in hot water of an extremity pre-hospital. This is only done in emergency department.
Exactly.
So localized cold injuries, early intervention, get it out of the cold.
Exactly.
All right. So, and then the last question for tonight, Max will ask us. This is the one we'll get wrong, because every time we've done this so far, we've gotten like 2 out of 3.
All right. A nasopharyngeal airway is contraindicated in which of the following situations?
Okay.
Okay. First is a patient who has an active gag reflex.
Okay.
Second is a conscious 8-year-old who cannot maintain an airway effectively. Third is a conscious adult without a gag reflex. Last is a patient with an ecchymosis behind one ear. Battle signs?
Patient with an ecchymosis. That's actually, I have not seen that term before.
Let's look it up.
I think we have to look up that term, which is tricky because that's not one that we are familiar with. Ecchymosis. If it's battle signs, I would not be surprised. It's bruising.
Bruising.
A discoloration of the skin resulting from bleeding underneath, typically caused by bruising. So they, of course, try to throw you off by not using the word bruising.
God forbid.
So name that one, say that one again.
A patient with an ecchymosis behind one ear.
Okay. So essentially saying battle signs.
Yes.
Like bruising behind the ears. Okay.
Okay. So right away.
I'm 100% lock on this.
Oh, so am I.
Yeah.
So if you have a conscious 8-year.
Let's hold on before we go. Like, so the question is, what is a contraindication for an NPA, a nasopharyngeal airway?
Yes.
Okay.
So first one, a patient who has an active gag reflex.
Well, an OPA is not allowed for, or is not indicated for a patient with a gag reflex. However, an NPA can be used in a patient.
It's almost an indication for it.
Well, yeah, it's for
its use.
Yeah. If they're not tolerating the OPA, then you can go to the NPA, and it can work in a patient that has an active gag reflex. Although it still may cause problems because they may still gag on it.
And your second one, a conscious 8-year-old who cannot maintain an airway effectively, again, is an indicator for the use of an NPA.
Right. And they're trying to throw you off the trail with conscious. And it's like, but you can use an NPA in a conscious patient if they can tolerate it. Yes. Right. Like that's the important thing there for these is like, they're not saying that they're not tolerating them. Yeah. They're just saying they have a gag reflex.
And then we have a conscious adult without a gag reflex.
Well, that's like, bread and butter for an NPA. It's like, okay, you could use an OPA in that.
Exactly. One. So clearly, I think it's an easy land on a patient with an ecchymosis behind one ear being some kind of head trauma.
I agree, because
which is direct.
The contraindication for an NPA is suspected skull fracture.
Yes.
Because if there is a skull fracture and you try and pass the NPA in, what happens?
You could do more damage.
You could do more damage because it what? It goes where?
Yeah. Into your airway.
Well, no.
It goes into your nasal cavity and into
right. But if you have a fracture inside the nose,
into your brain.
It can go into your brain.
Yeah.
Like it could poke things it's not supposed to poke. So that's the contraindication.
100%.
Yeah.
Okay. Clicking on it.
How are we wrong? No, I'm joking. We got it right.
We got all 3 right.
We got 3 for 3 tonight.
I think that the key is not having the pressure of Jonathan's knowing gaze.
It's possible. It's
his knowing gaze and waiting for his disapproval.
Knowing that he's disappointed in us if we get them wrong. So, no, I think that's a good, like, I think we worked through them correctly. Yeah. Like they were easy ones tonight, but
they were,
it's still important to use the rationale to figure them out. Cause sometimes they're worded incorrectly. So sometimes it also, like, a tip for everybody out there, read them multiple times, like every word.
Yeah. Cause like, I cannot tell you how many times I got it wrong because they asked for 2 right answers.
Yeah.
And I just read through it and didn't get to the part where they wanted more than one.
Yeah.
So like, read them twice, read them slowly.
Yeah.
Read them out loud, because sometimes when you read them in your head,
you put your own words in there.
And more importantly, like guys, Pocket Prep, indispensable.
It's very good. I wish they were a sponsor.
Yes, so do we.
Well, they don't have to be, because we'll tell everyone to use it anyway, because they're really good. Okay, so that is our student tip test prep of the week.
Jonathan, great job.
Great job, Jonathan. Hopefully you get a little bit of value from that, and the rationale and understanding how you should approach questions from 2 guys that just recently passed, I guess. Hopefully that's useful for you. But that brings us to the end.
It does indeed.
And that is, completing a 2-part episode, basically, between all the stuff related to the head, neck, and spine.
Yep.
all interrelated. I mean, a lot of trauma is interrelated.
Sure.
And we'll probably come back to this in a couple of weeks when we talk about multi-system trauma.
I have no doubt.
Because then we're touching on everything. Soft tissue, bleeding, spinal motion restriction, holes in places they shouldn't be, chest and abdominal cavity. Yep. So we've still got a few more sections left to go until we get to our multi-system trauma, which is kind of like the capstone.
Yeah.
Next episode, I believe we're talking about abdominal and chest injuries.
There's a lot of stuff going on there.
Yeah. Hopefully we'll be able to kind of consolidate it down, make it easy to understand. But we've got more coming. We're not done with the trauma block yet. We've still got some interesting things to show you guys. And, they're not a sponsor for this episode, but we have that chest and abdominal episode is going to be sponsored by Sam Medical again. They're great people.
They're awesome.
You should definitely check them out because they've been helping us a lot with really getting information to you guys on trauma because they're the name in trauma.
It's what they do.
So a little shout out to them and thank you guys for hanging out with us. Hopefully you enjoy this stuff that let us know how things are going for you. We love hearing from fellow students. Sometimes now providers, people have been sending us messages saying, hey, I just made it through. I graduated. I made it I got my first job in EMS and a 911 service. Please let us know. We love hearing that. And we hope that you guys have gotten a little bit out of this. If we could be a part of that journey in any way for you.
That's the whole reason.
Yeah. So, thank you guys for taking the journey with us, and we'll see you next time on the ride along. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing in